Hello everyone and welcome to another ECG of the week brought to you by RCSI Cardiovascular Society. And here is the clinical vignette, so you can just take a moment there to refamiliarize yourself with the case. I have taken the liberty of highlighting some important key features that will be helpful in determining the diagnosis. And let's go ahead and have a look at the ECG. Now, right off the bat, you probably are noticing something is kind of off about the ECG. But before we dive in, let's just remember we want to be systematic. So we're going to use the 6-step method to interpret this ECG. And just remember the 6 parts of the 6-step method are rate. So we'll determine the rate first, followed by looking at the rhythm, observing the P waves, the QRS morphology, the PR interval, duration, and then the morphology of the ST segment. So those are our 6 steps. So let's just start with the first one and determine the rate. Now, this, you know something is off in this ECG, so just to keep it straightforward, for our rate, we'll use the 10-second method. Remember, you can either use the 300 or the 10-second method, but just for this ECG, let's go ahead and use the 10-second method and see where that gets us. So remember, we're counting our peaks on the duration of this rhythm strip here. So we have 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13, 14, 15, 16. So that's 16 over the course of the 10 seconds. And using the method, we know that we take the number of our peaks, we multiply by 6, and that gives us a rate of about 96 BPM. And that's our rate there. You could try and use the 300 method, but it'll probably be a little tricky just because we have some abnormalities here in our QRS complexes, so determining the gaps between the boxes isn't as straightforward. Now on to rhythm. And remember, when we're looking at rhythm, we're seeing, is it normal sinus rhythm? Is it an irregular rhythm? Is it irregularly irregular? And usually what we do, right, is we take our peaks and then we look to see if they line up. Now, I'm going in between kind of odd R peaks here. And you'd see if we move it over, yeah, it doesn't line up with the next one, but it does kind of line up with every other R peak there. And if you were to do this just to show all 3 with that kind of like funky complex there, you'd see that actually does kind of line up going all the way down the ECG. So this actually is a normal sinus rhythm. You could say that the rhythm here is normal. Moving on to our P waves. So are there P waves present in the ECG? So we'll zoom in here and have a look at the rhythm strip. And yes, you actually do see P waves here. This is a P wave. That is a P wave, which is very good. And these P waves are followed by QRS complexes, which is the next kind of secondary step of determining your P waves. But you're obviously seeing that there's something going on here that looks like a QRS complex, but does not have a P wave before it. For instance, this one is here, but there's no P wave before it. This is the T wave, actually, of the previous tracing. So that is kind of our abnormality there. But you would say, yes, you have P waves, and where there is normal conduction, there is a QRS that follows. Now we get into the interesting bits with looking at our QRS morphology. Now remember, for a normal QRS, we're looking for a QRS that is less than 120 milliseconds, and that is 3 small boxes. Just a reminder. So if we're looking at this first peak, here is a nice, sharp, narrow QRS complex. The duration of it is maybe a little bit bigger than 1 box, which definitely fits. You can see that this one as well has a normal morphology, but this is very abnormal. This is a wide complex QRS interval there. And there's, like we said, there's no P wave before it. And you can count here that there's 1, 2, 3, at least 4 boxes there. So that would be that would be larger than our desired 120 millisecond window for our QRS duration. So you do have some normal QRSs here, but you also have wide complex QRS morphology as well. So then we look at our PR interval. Maybe we'll use this one here just to say, and remember the PR interval is the interval from the beginning of the P wave, which is here, until the beginning of the Q of the QRS, which is there. And the rule of thumb there for the PR interval is that you want it to be less than 200 milliseconds, and that's less than 5 small boxes. Just a reminder. And this one we have here is about 1, 2, 3, 4, which is normal. That's a normal PR duration. And you'd notice that in the previous, you have 1, 2, 3, 4 as well, normal PR interval duration. But of course, we don't have P waves for this waveform, so we can't determine the PR interval there. But we do have a normal PR interval where there are P waves going into QRS complexes. And last but not least, you want to see the ST segment. Now, looking here, this is kind of this is the end of the QRS complex. That's the S wave, and then this is the T wave. And then you'd expect, right, this to be the ST segment. Now, if you look back at our video from last week with the ECG basics, we talked about a few different morphologies for the ST segment. What we normally expect is for the end of the S segment to come back up and come back to the isoelectric line at the J point, flatten out, and then you'd go into your T wave. But of course, we're actually not seeing that here. This is a good example of ST depression. You can see the ST segment is underneath the isoelectric line, which is floating about there. And this is an example of upsloping. You can see there's a little slope there, ST depression going into your T wave. And that is persistent in all leads. It's happened, or in every waveform that has a normal conductance pattern. You see it there, and then we'll just look at the third one there again. And then you see this here. This actually is the ST segment of these kind of abnormal QRS complexes, and there is a classic finding in this week's diagnosis that will explain this, but you can see that this is meant to be a QRS complex. This portion of it is actually the T wave, and like the S is kind of buried in there. So we'll talk about that in just a little bit. So that is the kind of reading of our ECG. So let's talk interpretation. So what did we find? We were at a rate of about 100 beats per minute. It actually ended up being 96, right? Using the 10-second method. The rhythm is normal sinus rhythm, but there are those abnormal beats that were happening in between every normal conductance. We had P waves where there was normal conductance, and then for our QRS complexes, they have some normal morphology, narrow QRS complexes, but of course we had those irregular, wide complex beats in between each normal beat there. Where we had P waves, it's a normal PR interval, and then our ST segment was an upsloping ST depression. And you can see that predominantly in the inferior posterior-lateral leads. And we're talking about, like IVF, lead 3, lead 2. It's also here in V2, V3. So that is what we're looking at for our interpretation. And then what do we have here? This is a case of ventricular bigeminy, which is a subtype of premature ventricular complexes, and that is in a patient that has likely has secondary or is secondary to digoxin toxicity. And if you think back to the highlighted aspects in the vignette, that was kind of the clue to digoxin toxicity. So let's talk about PVCs. We have premature ventricular complexes. They are often called ectopic beats. You might see them referred to as such. And they arise from ectopic loci, different places in the heart outside of the normal conducting system. The cells in the heart have the ability to spontaneously depolarize. So that means that some cells in the heart are able to kind of bypass the His-Purkinje system and directly depolarize the ventricles without, the nice pathway that we know and love of electrical conductance. Normally, any ectopics would be kind of suppressed by the normal impulses in the conduction system. This is just an example of when that kind of goes haywire and we don't have that kind of consistent suppression of ectopic beats and the predominance of the regular standard conduction through the heart. And then ectopics can occur in many places. We're talking about ventricular ectopics this week, but you can have atrial and junctional ectopics as well. So more about PVCs. These are like the common findings. You're going to have that broad, complex QRS morphology. There's all sorts of abnormal morphologies that you can see there. These contractions are occurring before they're expected, so you're not, again, getting that conductance from SA node through the AV node into the His-Purkinje system and down into the ventricles. These are beats that are firing outside of that conduction pathway, and that makes a beat occur earlier than you'd expect. And usually, in certain cases, depending on what type of PVC you're talking about, you have a compensatory pause, which is the heart's attempt to try and reset and get back into the regular rhythm. So you might see a pattern where there are two R waves and that are normal, and then you have a PVC like this one here. And then you'll have a long duration of pause after the PVC until the next beat. And just kind of a rule of thumb for that is that the duration of time after the PVC is usually 2 times the normal RR duration. So as you can see, this is your RR duration normally. This is actually the expected place where you'd expect to find a beat, but we have an early ectopic complex there, and then the duration kind of in between that is 2 times this RR interval. And just the way that we have forward conductance through the AV and His-Purkinje system, if there are ectopics firing at other locations in the heart, other loci in the heart, you can get, especially with PVCs, retrograde conduction back into the atria as well. And then here's just a couple examples of different kind of types of PVCs, if you will. So this week we had bigeminy, which means that the ectopic beat occurs after every other beat. But we also have trigeminy, quadrigeminy, couplets in which 2 PVCs occur next to each other, and then something called non-sustained ventricular tachycardia. So this is where you have more than 3 consecutive ventricular beats, and that's kind of what you're seeing in this example here, that these are normal, and then you have 4 PVCs kind of going next to each other. And then just like we talked about couplets, I just wanted to show you an example of what couplets look like. So you have 1, 2 normal beats, and then you have 2 PVCs that occur next to each other, and that pattern is repeating, and you can see those 2 PVCs like occurring consecutively, and that's an example of what couplets look like. So what are our takeaways from PVCs this week? They are normal electrophysiological phenomenon. They happen. Actually, everybody gets them. They usually don't require intervention unless they are persistent. In the case of our patient who had digoxin toxicity, and there are many other causes, which we'll get to in just a little bit. The symptoms that you're looking for are like palpitations. It might be your heart feels like it's skipping a beat. We've all had that feeling before. But the important things to remember when PVCs become problematic is if it triggers another tachydysrhythmia. So you can get a PVC that it happens normally, but then it triggers ventricular tachycardia or an AV node reentrant tachycardia. So those are things to look out for in terms of making sure that your PVCs don't progress to kind of more serious syndromes. Now, again, right, they're usually benign, but there's one exception, which is in the context of patients who have prolonged QT. This poses a risk of triggering torsades de Pointes, and that is very well worth making sure to avoid. Because torsades, as we know, is very dangerous. And you can find other videos about AVNRT and torsades on our YouTube page. Check them out so you know what those look like and how to determine them on ECGs, but we're just trying to say that PVCs can occur before either of those. And then some common causes of PVCs. We've already talked about our gentleman with digoxin toxicity, but it can happen just with anxiety, sympathomimetics, beta agonist use, excess caffeine, it can be a cause of PVCs, and then, your kind of run-of-the-mill electrolyte imbalances can also be causes of PVCs. So that is it for us this week. I hope you enjoyed the video. Keep looking out for other videos for ECG of the week every week. We hope to bring some interesting cases to you, and you'll be able to find more cases, more ECGs, and of course refreshers on how to go about the process on our YouTube page.